Welcome to the Physician's Guide to Doctoring, a practical guide for practicing physicians. Dr. Bradley Block interviews experts in and out of medicine to find out everything we should have been learning while we were memorizing the Krebs cycle. The ideas expressed on this podcast are those of the interviewer and interviewee and do not represent those of their respective employers. This podcast is intended for medical professionals. The information is to be used in the context of your own clinical judgment, and those on this podcast accept no liability for the outcomes of medical decisions based on this information. As the radiologists like to say, clinical correlation is required. This is not medical advice, and even though the magic of podcasting may make it seem like we're speaking directly in your ears, this does not constitute a physician-patient relationship. If you have a medical problem, seek medical attention. And now, here's Dr. Bradley Block.
Dr. David Draghinas is an anesthesiologist in Dallas who made his first venture onto the World Wide Web with the Anesthesia Myths website as a way to help patients tell fact from fiction with regards to anesthesia. We talk about what he wants all physicians, especially those writing surgical clearance letters, to know about anesthesia. We also discuss his podcast, Doctors Unbound, where he interviews physicians who are doing interesting things aside from typical clinical responsibilities. As he curates only the finest guests, I was one of his interviewees a few months ago. Welcome back to the Physician's Guide to Doctoring. On today's episode, we have anesthesiologist Dr. David Draghinas. He's in private practice in the Dallas area, and he's actually had a presence online for a long time. He started out producing a website called Anesthesia Myths, which we're going to talk about today. Originally, he produced it for his patients to help them understand anesthesia better and obviously dispel myths, but we're going to be talking about anesthesia myths for physicians. And currently, he's also a podcaster as well. He has Doctors Unbound, where he talks to different doctors who are, as you would expect, unbound by physician stereotypes. They do things that are really out of the box and unexpected for typical physicians. So, Dr. Dave, thank you so much for taking the time to be on the show today. Clearly, you have a lot on your plate.
Hey, thank you so much for the invitation. I'm excited to be on the show, talk to you, and hopefully share some things about what I've been doing in anesthesia, all that kind of good stuff.
So first, let's just talk about your training. Where'd you go to medical school and residency?
Yeah, sure. So I trained on the West Coast. I'm kind of a USC lifer. So I was a biomedical engineer for undergrad at the University of Southern California, go Trojans. And then I stuck around for medical school. Left for just one winter. I was like, well, I need to get away a little bit. So for internship, went to University of Michigan. So I actually caught a real winter. One was enough for me. And then I got my butt back to Southern California where I did my residency in anesthesia.
And then what are you doing right now?
So now I'm in private practice in the Dallas-Fort Worth area. I had the Navy pay for 3 years of my medical training. So after I finished my residency, I went down to San Diego and I was a naval anesthesiologist for about 3.5 years, had a wonderful time taking care of our servicemen and women, their families. So did that for about 3.5 years down at the Naval Medical Center in San Diego. And then we knew that it was time for us to kind of move into private practice, start a family. And so after I finished that stint, I moved out here to the Dallas area and I've been here ever since and really enjoy it out here.
So what does private practice mean for an anesthesiologist?
Yeah, the anesthesia itself, anesthesia is anesthesia, but you probably have, different pressures, different processes when you're in private practice. So obviously, the stress for the anesthesiologist is that you always have to provide safe anesthesia care. But when you are in a private practice setting versus maybe an academic setting where there's teaching, there's residents, there's things like that, then the speed of everything kind of moves up. And so you have to be very efficient, still take great safe care of your patient, but do it in a very efficient manner.
And You started a website. How long ago was it that you started Anesthesia
Yeah,
Myths?
it's such a
Man,
it's
that's
such a
a
mouthful.
pointy. Yeah.
Started it probably like I believe it was 2012. It was right after I came to Dallas. I was here for about a year or so, and what I saw was I had a certain subset of patients, not a large subset, but significant enough, and these patients would show up, let's say, for elective surgery, and they knew about it for a week, a couple weeks, whatever it was, and they would show up just super anxious. And so I said to myself, what could I do to hopefully help alleviate some of that anxiety? And I found that talking to them, explaining to them, the different risks related to anesthesia. Sure, there's some risks, but for the vast majority of people, those risks are very small. And just explaining the process would have alleviated a lot of that stress and anxiety. And so I asked some of these patients, said, "Hey, you've been stressed for 2 weeks. What have you been doing?" And they're like, "Well, I've been Googling, these keywords, these topics, these anesthesia related words." And so I started doing that myself. And when I saw what was out there, what was popping up on the first pages of Google was kind of scary, whether it was misinformation or forums where, it was patients giving patients advice, just a lot of misinformation. And so, with a buddy of mine, who's also an anesthesiologist, we said, "Hey, why don't we create a site where we're not trying to be physicians for these patients, so it's not for patients per se, but it is for lay people. And so, how can we provide anesthesia information in simple to understand language?" That was the goal, just to provide that anesthesia information for people who, might be having whatever procedure. And they're just nervous about it, just to give them a little bit more reassurance about the process.
So they're not getting their information from like a horror movie.
Exactly.
Yeah.
It's so difficult because in a lot of movies, yeah, unfortunately, the anesthesiologist is usually like the scummy bad guy, who
The
leaves.
villain.
Yeah, either the villain or just the immoral person who just leaves in the middle of the case, or doesn't care, or it's just all of these bad stereotypes. And unfortunately, there's a certain number of patients who take that to heart, and I've got to sit there sometimes and say to them, "I'm not leaving the room. This is not like the movies," and just kind of explain these different things to them.
Well, if you're a good anesthesiologist, you're not memorable, right? Like if everything goes smoothly, they don't think about it at all ever again. And so it's the memorable events that end up becoming memorable, right? Become uh maybe lore or end up getting shared on Facebook or something like that.
Yeah, sure. And that's probably, what you're getting at is probably the crux of, online reviews for physicians, right? Because you have, 100 great outcomes with patients, but, they don't bother to leave you a review unless you probably prompt them, because, they don't think about it. But that one person who either you rubbed the wrong way, or something happened,
Maybe
you know,
they're IV infiltrated.
yeah, something like that, and then all of a sudden that's the person who's going to go online and let everybody know about it. So it's tough. All physicians deal with that. It's part of the job, unfortunately.
So what we were going to talk about today is anesthesia myths, and I really need to enunciate that for physicians. So the first question is, if you are with a med student and you know they're going into something non-surgical, what is it that you want them to take away? Put another way, what are some of the myths that they might have about anesthesia that you're going to need to dispel?
Sure. So probably, as far as a lot of people think about going on their anesthesia rotation, and probably the top thing that comes to mind is probably intubations and IVs. And it's okay to get that experience. That has its place. I would say probably one of the things that's more overlooked is how to properly ventilate a patient, mask ventilation, because you don't necessarily need to know how to intubate a patient, but if you can mask ventilate a patient, you can keep that patient alive until help gets there. So, whenever I've, dealt with trainees who come through my OR, I've always tried to emphasize that, number one, to them, teach them how to hold a mask properly and properly ventilate a patient. So I think that is one thing that comes up and is really important. And then, they want to get some IV experience, sure, that can help, intubations, all that kind of stuff. But I would say that's one thing that's maybe sometimes missed and by people because it's not that interesting, right? So, oh, I got the intubation, but the mask ventilation is probably more important.
Right, because the likelihood that they're going to be called upon to intubate at some point pretty low.
Right.
The likelihood that they're going to be at a code and they need to mask the patient,
Hmm.
especially during their training, is significantly higher. And as an ENT, we know a bit about the airway, so I would add to that: don't underestimate the value of an oral airway.
Yeah, for
Right, if you're
sure.
having trouble ventilating, get that tongue out of the way, put an oral airway, and it's likely to make it significantly easier for you.
Absolutely.
So I actually had surgery this morning, and so I asked my anesthesiologist what thoughts he would have about something like this, and he referred specifically to physicians giving clearance, right? So a primary care physician is giving clearance before surgery, and he said a lot of times they'll say things like, "Well, cleared for local anesthesia" or something along those lines. And he said that I think it's a little mismatch of what's being asked, and he said, "Don't tell me what to do. Tell me about the patient." And I thought that was really appropriate because ultimately, who's giving clearance for surgery? It's the anesthesiologist, right? Because you guys are the gatekeepers, and if the lungs are clear to the primary care physician, but you guys hear some wheezing and asthmatic, you're you're going to take that clearance and turn it right around. So I thought that was an excellent point. Tell me the patient's story. Well, they have a family history of cardiac disease, and their last EKG was then, their last echo was then, and these were their labs. And I think they're still have some risk, but this is as good as they're going to get. And then the anesthesiologist can make as informed decision as possible.
Yeah, absolutely. Probably if you ask any anesthesiologist, it really puts us in a bad spot if somebody um, recommends a particular type of anesthesia because it may not be the best plan for that patient. But when another physician has suggested that, especially a physician that is not an anesthesiologist, now you've already planted that seed into the patient's head, and it becomes more difficult for me to get them to buy in to the plan that I think is best. This is one of the things actually that comes up a lot. And what I would say is, we're not looking for quote unquote clearance. What we're looking for our consultant colleagues is for more information that'll help us take care of the patient. So what I would say, let's say cardiology comes up as an example quite often, right? Where we send a patient to a cardiologist. Well, what are we really looking for? We're looking for kind of two different things. What is the significance of the disease process that the patient has, because that may impact my anesthetic. It may impact the type of anesthesia induction agents that I might choose. A patient that has a poor ejection fraction might get a different type of induction agent as somebody else. And number two, what I'm looking for is anything that this patient has within that disease process, or for that specific organ or whatever that specialist is looking at, can anything be optimized? Because if we're talking about elective surgery, we'd like to know if there's anything that can be optimized prior to elective surgery. Now, if it's an emergent surgery, then all bets are off. We have to take that risk. We do the best we can for that patient. But those are kind of the big things that we look at. And when somebody recommends spinal, now it puts us in a bind, because now we've got to explain, if we don't think that spinal is the best option, why it's not.
And then it's tough to manage that situation in terms of like helping that referring physician to save face,
Sure,
right?
that
Because
too.
now
Yeah.
you're stuck contradicting the physician that they've had a long relationship with, and you're this new person coming in who's contradicting their trusted doctor. So that always makes it for a challenging situation for all parties.
Yeah, for sure. There's a story, and I don't know if this is more lore or if it actually happened, but I don't even think I was a resident. I was a med student rotating through anesthesia, and there's, one of these very, very vocal and boisterous attendings, and he told a similar story of one of his mentors, who was like chair of the department or whatnot, and one of these patients gets a recommendation from, I forget what specialist, and they said recommend spinal for the anesthetic. So the story goes that this particular anesthesiologist brought the patient to the operating room, got the patient set up for a spinal, and then said, "Page Doctor So and So." Who had recommended the spinal, and supposedly that that physician shows up, and he looked at that person and said, your patient's ready for their spinal, and it's sort of jaw dropping, because obviously they weren't well equipped to place a spinal. So
Yeah.
don't make those kind of recommendations. Just we really appreciate the expertise of our specialist colleagues that consult for these patients. It really helps us get the patient through the perioperative period, as safely as possible. But really, those are the things that we're looking for. We're looking for the significance of the disease process. We're looking for anything that can be optimized there so we can best take care of the patient.
What are the risk factors? What can be mitigated and what can't?
Sure. Yeah.
Yeah. So let's say you have a med student rotating with you, and now you know they're going into a surgical specialty. So you know they're going to be on the other side of the curtain from you. Is there, aside from bag mask ventilation, is there anything that you want a future surgical colleague to know about anesthesiology?
Well, what I would say is that the surgeons that I've worked with that just impress me the most, if I can put it that way, are the ones that understand the anesthetic implication, and what we do and how that correlates with the surgery. So to give you an example, I was working with a surgeon some time ago, and got a phone call from the surgeon, very experienced surgeon's been doing this for years and years. And he says, "Hey Dave, we got this patient, and this patient has a difficult airway." Now, as an anesthesiologist, okay, that makes us kind of perk up, trying to, we got to do a little more research exactly, what was difficult, etc. But then the surgeon said to me, now the surgery was a hernia repair. Typically with a hernia repair, we're gonna paralyze and intubate a patient because we're getting intra-abdominal. And when you intubate a patient, difficult airway, there's certain things there. So, but this surgeon said to me, says Dave, he's like, I can do this case with an LMA. And what that surgeon was telling me is he understood our anesthetic. He understood that with an LMA, I don't need to paralyze a patient. I can slip that in without having to, DL and intubate the patient. So, he was giving me more options on how to safely do that anesthetic because he understood, my side of the drape as well. And so I appreciated that tremendously, because it gave us another option. Had all the difficult airway stuff in the cart, but we were able to safely do the case with an LMA, and the patient did great. And we didn't have to take on that risk of doing either an awake intubation on a patient that could be a lot more uncomfortable, or going down the road of difficult intubation.
So if the patient's not paralyzed, they're still breathing, right?
Hmm.
Is that considered general anesthesia? Like how do you define general anesthesia versus conscious sedation versus unconscious sedation versus I think sometimes it gets confusing for surgeons. Um, One thing that's confusing is how do you define surgery, right? Like if I'm
Sure.
doing ear tubes on a kid, I'm doing it in the operating room. It's technically surgery. When I'm doing it in the office, like, is that technically surgery? Is it an office procedure? Like if I'm doing something like that on an adult? And I think basically what it comes down to is it's defined by the CPT code. And then you have some insurance companies that will put certain procedures in their surgical deductible. And so then it's the insurance company that's deciding what qualifies as surgery, right? Not any agreed upon nomenclature. So what about for anesthesia? What
Sure.
defines the different types of anesthesia?
Sure. And and it's a spectrum, and it's it can be tough and it can be confusing, because you can go from a very light sedation to a moderate sedation to a deep sedation to general anesthesia. And you know you can use the same drugs to accomplish all those things, but the dosing and the timing of it matters. So basically with general anesthesia, you've got somebody that is losing consciousness, they're losing their airway reflexes. that's going to indicate that they're under general anesthesia. It does not necessarily mean that you're using a paralytic, which you'd typically require for an intubation. Not always, but usually for an adult, you'd be using a paralytic or something like that. But with LMAs, typically in this country, we're not paralyzing. We're using something like propofol. It works very fast. You lose the airway reflexes. They stop breathing, right? Because propofol causes that respiratory depression, especially when you're giving a general anesthesia type dose. You're able to slip in an LMA, and within a couple minutes, that patient is breathing on their own often. So it's kind of hard to explain, because like I said, you're using the same drugs and you can achieve all those different levels, but it's all about the dosage and the timing, and how often are you giving it, and what exactly are you trying to accomplish.
And is there like an agreed upon? It was my impression that general anesthesia was based on the depth of anesthesia. So if the patient isn't arousable to gentle stimulation, then it's general anesthesia, and it's conscious sedation if they are arousable. So it's a question of more of, like you said, for the doses then lead to a certain amount of arousability, or is it more like, if the patient is paralyzed?
Sure. That
There's
I
a
mean that
couple.
well, I mean that is going to be part of it, and like I said, with general anesthesia, you're getting to that point. You're getting past that point where they're arousable, where, like I said, they're losing their airway reflexes. They're losing consciousness. They're not going to be arousable with that. Um, so that's part of it. But a lot of times patients and other people don't realize that the paralytic drugs are different than the drugs that induce anesthesia. And I wasn't thinking about bringing it up in this way, but unfortunately there was a bad outcome recently at a hospital where it didn't happen in the operating room, but a vial of vecuronium was mistaken, a vial of Vecuronium was mistaken for Versed. Nurse thought she was giving Versed, but gave Vecuronium to a patient in a radiology suite, and that patient ended up dying. Right, and what a horrible death, because that patient got paralyzed, could not move a muscle, basically suffocate, and
Yeah.
they're awake the whole time because there was no sedative given. So that patient is there awake, obviously, and till the very end there. But what a horrible way to go.
I think that's the case where the nurse is being she was arrested for effectively a medical error.
Yeah, I've heard that. That's the latest. I haven't read the latest article, but I've heard that now you're dealing with an arrest, and
Yeah, that's
and,
crossing a line. I
and
know, as physicians and healthcare practitioners in general, that certainly causes us all to quake a bit in our boots if this is going to be some type of a trend
right. If you're
for
getting
medical
into,
errors.
yeah, if you're getting into criminality of it,
Yeah.
that's crossing a line. Um, Not
Well,
familiar
let's
with.
bring it back towards anesthesia.
Yeah, for sure.
That's what we're talking about. So, um, if there are any med students listening, right? Is there anything about your specialty that you weren't aware of until you became an attending?
Sure. So there's a couple of things, and one that I would stress, and I see this as as kind of a myth with the specialty, and I got this, from some of my classmates when it's kind of like you go off to third year, do all your rotations, and you come back at the end of third year, beginning of fourth year, and everybody's like, hey, what are you going into? Hey, what are you going into? And when I told some of my friends I was going into anesthesia, some of the responses I got was like, why you actually can talk to people? So so one of the myths is that if you're an anesthesiologist, you don't need good communication skills. Um, Nothing could be further from the truth. You have a very short amount of time to gain the confidence and trust of that patient. So I would say that you need excellent communication skills to be a good anesthesiologist. So that's something that some excuse me sometimes medical students or other people don't realize about the field. Number two, I would say the human body is very resilient. If you're doing this long enough, you see that, you recognize that. But I would say the other thing, and it kind of goes back to the communication and the soft skills. Once you're competent as an anesthesiologist, you've gone through your training, you've gone through your boards, you're competent. These soft skills really take over and are really essential. How are you able to deal with different surgeon personalities? How are you able to be a good consultant from them? Are you able to talk to them if there's a cancellation? Are you able to talk to them in a manner where you make them understand that this is something that is best for the patient? So you're not only looking out for the patient, but you're also looking out for the surgeon, because if there's a bad outcome, now everybody is involved in that. How are you able to do that, navigate with hospital, with or charge nurses? Are you definitely maneuver and work out the or workflows? A lot of these soft skills really become important to safely take care of patients, and then be efficient with that or throughput. So those are some things that probably don't get realized by med students when they're first looking at the field.
If rapport isn't for you, then don't go into a specialty where you have to rapidly build rapport with someone so that they trust you with their life.
Absolutely.
Okay. Are there any other myths about your field that you find doctors believing that you want to discuss?
I think that covers it pretty good. Um,
Then let's talk about Doctors Unbound.
yeah, so Doctors Unbound is this podcast that I've been doing for about 16 months now, and it was a little bit of scratching my own itch. I wanted to highlight physicians like you were talking about earlier, who are doing these really interesting, cool things, outside of their typical clinical practice. I'd met some of these physicians. Uh, I'd been impressed with them. I learned from them. And I thought to myself, man, I just wish there was, something out there where, we can learn from each other. Um, we can help each other out, build this community. And I just was so impressed that there's doctors doing awesome things. There's people out there who are financial bloggers who are really impacting the finances of physicians. There are people out there that have decided to step into the political arena, and with how divisive our politics are these days, I'm seeing more and more physicians on both sides of the aisle doing that. And I think that's important, because we need physicians who care, who are knowledgeable, to be out there affecting policy on a local, state, and national level. So it's just really cool to see these physicians that have mastered, medicine, but then also have ventured out and are doing these really awesome things. So I get to talk to them at Doctors Unbound. Podcast that I put out every week. Every Monday, there's a fresh new episode, and an episode will last anywhere from about 20 to 45 minutes. And we talk about whatever the expertise that physician has, and then we also do some learning points, some takeaway points for the audience as well. So it's been tremendous for me. I tend to pick up two or three things from each guest that I have on. You've been on the podcast, so thank you very much. I really want to thank you publicly for coming on. Learned a lot from you as well, and it's been just a tremendous growth for me personally, and being able to put it out there to the physician community.
Well, clearly, I highly recommend that episode. But that and the other episodes, where can people find you online? Where can people find the podcast, and where can people find Anesthesia Myths?
Sure. So the podcast is Doctors Unbound, and it's just at doctorsunbound.com. What you'll find there is, for every episode, there is a blog post or show notes, if you will, and what that includes is the podcast player. So if you don't listen to podcasts any other way, there's an embedded podcast player right there where you could listen to the episode. I have highlights of the episode, and then I actually include transcripts, so full transcripts of every episode, because some people would rather read than listen. So all of that is available there. But you can find the podcast if you listen to podcasts regularly, like many of your listeners obviously do. You can find it on your favorite podcatcher, whether that's Apple Podcasts or Stitcher or something else, and just search for Doctors Unbound, Unbound, and you'll find it there. And I would appreciate it if you listen, subscribe, and if there's any topics that you like, or you want to give me some feedback, I'm always happy to hear that.
And then Anesthesia Myths is anesthesiamyths.com.
Yep, anesthesiamyths.com. Now that's both sites, but that site especially needs needs a redesign. And so, like you said, we started that site in 2012. It's now just me. It's a solo thing now. So the great thing about some of this anesthesia content is that it's evergreen. So once you put up a blog post about anesthesia, general anesthesia side effects, there's not a whole lot that changes. So that was the beauty of it. But it's in need of a redesign. That's in the works right now. So if you go there, it's not going to look so pretty. It's going to look prettier soon. But check it out if you have any patients that have interest in learning about different anesthesia topics. We cover stuff from general anesthesia to labor epidurals to spinals to regional anesthesia blocks. All that kind of stuff is covered there. So go ahead and check it out. And I would say one more thing: if you're a physician that is either an anesthesiologist or maybe a surgical subspecialist or something like that, and you would like to write for it, like, hey, you want to write about a specific topic, that is, somehow related to anesthesia, contact me in any way. And you could put a post on there, and I'd be happy to give you credit, obviously, and link back to either your website or your social media profile, or wherever you would like that link back. So if somebody's looking to contribute that way, I'd be happy to collaborate.
Sounds fantastic. I look forward to looking at the redesign, and then maybe when you do that, you could, I guess, take down the articles about ether, right?
Yeah, it's funny. I had a patient not too long ago, and they were telling me that they had ether way back when they were a kid, and I was like, man, we don't train on that anymore. We don't train on halothane. We don't train on ether anymore. That's
I think
long gone.
halothane. I think halothane might have been on one of my steps at some point, and I'm not. I guess I finished medical school in 2006, so but I think it hadn't been used anymore yet. They hadn't updated the exam yet.
No, I haven't seen it in my training. The one halothane story I have is I was in Iraq as a naval anesthesiologist, and we were there doing a case on base, and some of the guys pulled out something called a draw over vaporizer, which is the first time I saw that, and looked on there. It said halothane. You were supposed to put halothane in there, but we used isoflurane, which is kind of has some similar properties, and we did a case with that just because we thought we might need to be mobile in a war environment, and that was one of the options that we would have. So there's like 3 anesthesiologists that say, all right, we're going to do a case with this more mobile draw over vaporizer. So that's the closest I got to halothane. We actually didn't have
Halothane.
it.
It was labeled halothane.
It was labeled exactly. That's it.
All right. Well, Dr. David Dragrinas, thank you so much for taking the time to talk to us. I've learned a lot, and it's been a fun conversation.
Hey, thank you so much. It's been my pleasure to be on the show.
That was Dr. Bradley Block at the Physician's Guide to Doctoring. We can be found at physiciansguidetodoctoring.com or wherever you get your podcasts. If you have a question for a previous guest or have an idea for a future episode, send a comment on the webpage. Also, be sure to leave a 5-star review on your preferred podcast platform. Our show is produced by Gilfry Studios in New York City. You can find them at gilfrystudios.com. Our theme music was written by our show's producer, voice actor Carin Gilfry.